Welcome to the Deep Dive. Today we're going on a deep dive into a topic that's incredibly important for many people. Preparing for, undergoing, and, well, recovering from an endovascular procedure for peripheral arterial disease.
hmm
We've got a stack of sources here, research, clinical guidelines, notes, all sorts of things. And our mission is to turn all this information into a clear, step-by-step roadmap for you,
Yeah.
whether you're the patient or maybe a caregiver supporting someone through this.
Right. And peripheral arterial disease, often just called PAD, it affects the arteries, usually in the pelvis and legs, sometimes the arms too. These are the vital vessels carrying that oxygen-rich blood away from your heart out to your limbs. Our sources explain that the most common cause is atherosclerosis, and they describe it as a chronic inflammatory disease. Now, that's a key point. It's not just simple blockages, it's really an ongoing process where this fatty material called plaque builds up inside the artery walls, and this plaque, it makes the artery stiffer, narrower over time. When this narrowing causes, significant blockages, it drastically restricts blood flow. That leads to symptoms like leg pain when walking, and sometimes it requires procedures like the endovascular one we're discussing today just to restore that crucial blood flow.
Exactly. And navigating that whole journey, from the moment you find out you need a procedure right through to getting back on your feet, it can feel, well, overwhelming, like navigating a maze. So our goal today, using all the info in these sources, is to try and simplify that. We're going to break it down into clear steps. Getting ready, what happens when you arrive and during the actual procedure, what recovery looks like right afterwards and then back at home. Also, what warning signs to look out for, and maybe most importantly, how to manage PE as a long-term thing, to keep those arteries healthier for the future. Think of this deep dive as your guide, helping you feel more informed, maybe a bit less overwhelmed. So let's unpack this, starting with those vital steps you need to take before the procedure even happens.
Absolutely. Preparation truly is a foundation for a smooth experience and hopefully a successful outcome. Our sources really emphasize that what you do leading up to the procedure is crucial. Two major areas stand out: undergoing the necessary pre-procedure assessments and, very importantly, carefully managing your medications.
Okay, so let's start with those assessments. Walk us through that. What exactly will the medical team be looking at and, looking for?
Well, based on the sources, the preoperative evaluation is actually quite thorough. It usually begins with a really detailed history and a physical examination. This is especially important if you already have other health conditions because the team needs that complete picture of your overall health status. During the physical exam, they'll pay very close attention to your arterial system. So they'll be checking for pulses in your feet and legs,
Right.
which gives them a basic idea of the blood flow downstream. The sources also mention specific tests like the Allen's test. That's particularly if they're thinking about using an artery in your arm for access.
The Allen's test, what's that for?
It's a simple check, really. It confirms there's good backup blood flow to your hand from other arteries. So if the artery they might use for access were temporarily blocked during the procedure, your hand would still get enough blood. It's a safety measure.
Ah, okay. That makes sense. A good safety check. What else are they looking for during the physical exam?
Well, they'll also check your blood pressure, and they'll do it in both arms. This is interesting because the sources note that a significant difference, they mention specifically 20 millimeters of mercury or more between your arms. That can actually be a sign of blockages or narrowing in arteries, maybe higher up, closer to your shoulder, like the subclavian arteries.
Huh. So that gives them clues beyond just the legs.
Exactly. It helps the team understand the extent of your arterial disease. They'll also review your medical history very carefully for specific things like any previous vascular access procedures you might have had, or if you have any implanted devices, say pacemaker wires. These details can definitely influence how they plan your specific procedure.
So it's really about gathering this comprehensive picture, isn't it? Your
Yeah.
individual anatomy, your overall health.
Yeah.
And you mentioned imaging as part of this prep too.
Oh, absolutely. Routine preoperative duplex ultrasound imaging is highly recommended in the sources. This is a non-invasive test. It uses sound waves much like the ultrasound used in pregnancy, but it creates images of your blood vessels and, critically, allows them to measure blood flow.
Okay.
The sources indicate it's used to assess both your arteries and sometimes your veins, too, if venous access might be needed for some reason. For the arteries, it's invaluable. It helps identify exactly where the atherosclerotic disease is located, and it creates this detailed map of your arterial system in the affected limbs. Shows exactly where the blockages or narrowings are. For veins, if access might be needed there, they use it to ensure the veins are suitable, checking their size, making sure there are no obstructions, and confirming they connect properly to the larger central veins.
And are there specific things they measure on the ultrasound, like vessel size or anything like that?
Yes, the sources do mention certain criteria they look for, particularly if they're considering using an artery or vein in the arm or forearm for access, though. Groin access is still the most common for leg PAD procedures. They're looking for arteries or veins of a sufficient diameter, basically large enough to safely insert the necessary tools without causing damage. While the sources give specific numbers like 2.0 millimeters for arterial luminal diameter or 2.5 millimeters for vein diameter, the key takeaway for you as the patient is that the team is using this imaging to confirm your blood vessels meet the requirements for safe access and to build that precise map of your disease. This careful mapping helps them plan the best approach for your procedure. And if the initial physical exam or the ultrasound shows anything, questionable or unclear, they might need to do further imaging. Things like contrast arteriography, which uses X-rays and a special dye to get even more detailed pictures of your arteries.
It's clear that this initial assessment phase is incredibly thorough. It's combining your personal medical history, a physical exam, and this detailed imaging to really create a personalized plan.
Precisely. It's all about understanding your unique vascular anatomy and your health profile before they proceed. Now, the other critical piece of preparation is medication management, especially blood-thinning medications.
Right, this sounds really important. What did the sources highlight about things like aspirin or clopidogrel? A lot of people take those.
This is absolutely vital, and it's where clear communication with your doctor is just paramount. You cannot overstate this. The sources discuss using antiplatelet therapy, often aspirin and clopidogrel, sometimes together, which they call dual antiplatelet therapy or DAPT. They talk about it in various vascular procedures, like putting stents in the carotid artery in the neck, and also just as a general strategy to prevent future cardiovascular events like heart attacks or strokes.
No.
Now, while these sources, of course, cannot give you specific instructions for your procedure, only your own doctor can do that based on your situation. They do provide a really strong cautionary note that's highly relevant. For instance, one source specifically mentions that taking clopidogrel within 7 days of non-cardiac surgery carries an increased risk of bleeding.
Wow, okay, 7 days.
Yeah. And that specific detail powerfully underscores the fact that these medications, particularly any blood thinners, must be discussed with your healthcare team well in advance. Your doctor will review every single medication you take, prescriptions, over-the-counter stuff, even supplements or herbals, and give you precise instructions, which ones to stop, which to continue, and exactly when. This plan is tailored specifically to you, your health, the procedure planned, and it is absolutely crucial to follow it exactly.
No wiggle room there.
None. And the sources also mention that sometimes antibiotics are given just before the skin incision. Now, this is noted in the context of preparing for open surgery, but it's a pretty common practice applied to many invasive procedures, including endovascular ones, just as a precaution to help prevent infection. So don't be surprised if that's part of your pre-procedure routine as well.
Okay, so the big takeaways for preparation are getting that detailed medical evaluation with exams and imaging to map everything out, and then having a critical, careful discussion with your doctor about all your medications, especially blood thinners, getting those precise instructions and sticking to them without fail.
That's it, exactly. Diligent preparation is really your first active step in helping ensure a safe procedure.
All right, prep covered. Now, what about things to explicitly avoid or stop doing in the days or hours leading up to the procedure?
Right. Based on everything we've just discussed from the sources, particularly around medication management and just the general requirements for undergoing any procedure with sedation or anesthesia, there are definite things you'll need to talk to your doctor about avoiding. The absolute foremost thing, and we need to reiterate this, is confirming with your doctor exactly which medications, especially any kind of blood thinner, whether it's antiplatelet agents like aspirin or clopidogrel, or other anticoagulants like warfarin, or the newer ones you will need to temporarily stop or maybe adjust the dose. As we noted, the sources clearly highlight that increased bleeding risk associated with taking certain blood thinners too close to a procedure.
Right, that clopidogrel example was pretty clear.
Exactly. Your vascular care team will give you a specific, personalized plan for all your medications. You must follow it precisely. This is really not something to guess about or, make your own decision on. It's too important. Beyond the medications, the general preparation mentioned in the sources, like for surgery or angiography procedures, it strongly implies a period of fasting before your endovascular procedure.
Meaning no food or drink.
Correct. You'll be instructed not to eat or drink anything for a certain number of hours beforehand. This is really important for safety, especially if you'll be receiving sedation or anesthesia. Your doctor or the hospital staff will give you very specific instructions on exactly when to stop eating and drinking. Usually it starts the night before or maybe early the morning of the procedure. So the critical message here, really supported by the information in these sources, is to avoid making any assumptions. Don't guess about what you can eat, drink, or which pills to take before your procedure. Always, always follow the precise, detailed instructions given to you by your vascular care team. If you are unclear about absolutely anything, ask them. It's far, far better to ask than to risk a complication by doing the wrong thing.
That is crystal clear and incredibly important advice. Get explicit instructions from your medical team about meds, food, and drink, and follow them perfectly. No assumptions, no guesswork.
Absolutely. Those instructions are designed specifically for your safety. Don't deviate.
Okay, preparation and what to avoid are clear. Now let's fast forward. It's the day of the procedure. You've arrived at the hospital. You're going through the admission process. What generally happens once you're admitted and getting ready to go into the procedure room?
Okay. Once you're admitted to the hospital for your endovascular procedure, the focus shifts to getting you ready for the procedure room itself. Sometimes they call it a cath lab or an angio suite or an interventional radiology suite. You'll likely be asked to change into a hospital gown, of course, and then you'll be positioned on the procedure table. Usually this is lying flat on your back, what they call the standard supine position. Then the medical team, often nurses or technicians, will start attaching monitoring equipment. The sources specifically mention devices to track your blood pressure continuously.
Okay.
An electrocardiogram or ECG using sticky pads on your chest to monitor your heart's electrical activity, and a pulse oximeter. That's usually a little clip they put on your finger to measure the oxygen levels in your blood. All this allows the team to keep a very close watch on your vital signs throughout the entire procedure.
Makes sense. Constant monitoring.
Yes. And supplemental oxygen should be readily available, and the sources say it's routinely used, particularly if you receive something called conscious sedation.
Conscious sedation. Is that like being put fully asleep?
Not quite. Conscious sedation uses medications, usually given through your IV, to help you relax and feel comfortable. You might feel drowsy, maybe even doze off a bit, but you're typically still able to breathe on your own and follow simple instructions if the team needs you to, say, hold your breath for a moment. It's lighter than general anesthesia.
Okay, that's good to know.
Right. And intravenous lines, or IVs, will definitely be placed, often by the anesthesia team or nursing staff. These are essential. They're used for giving fluids, any necessary medications for that sedation or pain relief, and also for administering the blood thinners during the procedure itself. The sources also mention that sometimes an arterial line might be placed. That's a special IV that goes into an artery, usually in the wrist, for very precise beat-to-beat blood pressure monitoring, but that's not always needed. A Foley urinary catheter, that's a thin, flexible tube put into the bladder to drain urine, might also be inserted using sterile technique.
A catheter. Why is that needed?
Well, it's mentioned in the sources in the context of general surgical prep, but it's sometimes used for longer procedures. It keeps you comfortable so you don't have to worry about needing to use the restroom. And it also allows the team to monitor your fluid balance accurately, which can be important.
Okay, so they get you settled, hooked up to all the monitors, make sure they have the IV access. What about the area where they'll actually, go in?
Right. The access site. The area, or maybe areas where the doctor will access your arteries, will be very carefully prepped. This involves thoroughly cleaning the skin with an antiseptic solution, something like betadine or chlorhexidine, to kill germs and minimize the risk of infection. Now, the sources emphasize preparing both groins, even if they only plan to use one side.
Both. Why both?
Good question. The groin area gives access to the large common femoral artery, which is the most common starting point for peripheral artery procedures in the legs. Preparing both sides gives the doctor flexibility. They can choose the best femoral artery for safe access based on your specific anatomy seen on the ultrasound, or if they encounter an unexpected issue on one side, they have the other side ready as a backup.
Planning ahead makes sense.
Exactly. And the sources also note, as we mentioned, that sometimes access from the arm, like the brachial artery near the elbow or the radial artery in the wrist, is used. This depends on which arteries need treatment or if groin access isn't ideal for some reason. So if that's the plan, your arm might be prepped as well. And finally, just before they start the actual intervention, there's a really important safety step highlighted in the sources. The entire medical team will conduct what's called a timeout, or a safety
A
checklist.
timeout, like in sports.
Sort of. It's a deliberate pause where everyone stops what they're doing. They verbally confirm several key things. They have the correct patient, they're doing the correct procedure, and they're working on the correct side or site of the body. It's a final double check, triple check, really, to ensure everything is perfectly aligned before the procedure begins.
That timeout step sounds like a crucial layer of safety. So, okay, on admission, you're getting settled, monitored, lines in place, the access area is prepped sterilely, and the whole team does a final safety check. Sounds very systematic and really focused on safety.
It absolutely is. Each step is carefully designed to prepare you and the team, and to ensure the highest level of safety before the intervention starts.
Okay, let's move into the procedure itself then. Everything's prepped, the timeout is done. What happens once the doctors actually start working inside your arteries?
Right, this is where the endovascular part really happens, literally meaning inside the vessel. The procedure is performed in that specialized room, the angio suite, using standard angiographic equipment. This basically uses X-rays to create real-time, movie-like images of your blood vessels. A critical safety measure the sources point out right away is the strict attention the team pays to preventing air bubbles from getting into your bloodstream. That's called air embolization, and they take very careful steps to avoid it.
Okay, good to know they're watching for that. So how do they actually get into the artery?
The first step is gaining access to your arterial system. As we discussed, the most common and often preferred approach is through the common femoral artery in the groin. And the sources specifically highlight the benefit of using ultrasound guidance to locate and puncture the femoral artery for access.
Using ultrasound for the needle stick.
Exactly. This is a significant detail because using ultrasound to guide the needle has been shown in studies mentioned in these sources to actually decrease the rate of hematomas, those large, painful bruises or collections of blood in the groin area after the procedure. It helps the doctor get accurate access, hopefully on the first try, right into the best spot in the artery.
That makes a lot of sense. Precision matters there.
It really does. Now, the sources also mention that other access points can be used if needed. We talked about arteries in the arm, like the brachial artery near the elbow, or even the smaller radial artery in the wrist. Or sometimes they might need to access smaller arteries further down in the lower leg, or even the foot. This is called tibial or pedal access. These alternative sites are particularly useful if getting access through the groin is difficult for some reason, maybe due to scar tissue or severe disease there, or if the blockage they need to treat is very far down in the lower leg or foot and it's actually easier to approach it from below. If they do use tibial or pedal access with ultrasound guidance, the sources note they might position your foot in a specific way, like pointing your toes downwards, plantar flexion, just to get a better ultrasound view of those smaller arteries.
Wow, okay, so they have multiple options depending on what's best for the patient and the specific blockage location. Once they have that access, what's next?
Once safe arterial access is obtained, they insert something called a sheath. It's essentially a small, hollow tube, like a port, that stays in the artery temporarily. It has a valve to prevent bleeding back, and it provides a pathway for inserting all the other tools they need.
Okay, the sheath is in place.
Right. Then you will be given medication to thin your blood systemically, usually through your IV. The sources mention medications like heparin or sometimes argatroban for this. This anticoagulation is absolutely crucial. It prevents blood clots from forming on the wires or catheters or in the artery itself while the team is working inside the vessel.
Makes sense. You don't want clots forming during the procedure.
Definitely not. Then they start injecting contrast material. This is that special liquid dye that shows up clearly on the X-ray images. Thin, flexible tubes called catheters are threaded through the sheath and carefully navigated through your arteries, often over a guide wire. The contrast is injected through these catheters, and the X-ray machine takes pictures or movies. This process is called angiography. It allows the doctor to visualize your arteries in real time, pinpoint the exact location and severity of the blockages, and plan the treatment. The sources do note that for patients who have kidney problems, the team might use a diluted mixture of the contrast dye and saline solution just to reduce the contrast load on the kidneys.
Oh, that's considerate. Are there other options if contrast dye is a major concern?
Yes, the sources mention using carbon dioxide gas as an alternative contrast agent in some situations. However, they also note it has limitations. The images might not be as clear, especially in areas where there's a lot of calcium buildup in the artery walls, which is common in PD. So it's an option, but not always suitable.
Okay, so they've got the pictures, they see the blockage. How do they get through it?
That's where the guide wires come in. These are very thin, flexible wires, often with specially designed tips. They are introduced through the catheter. The doctor carefully manipulates the guide wire, watching it on the X-ray screen, to navigate through the arteries and attempt to cross the diseased or blocked segment. Now, a critical safety principle highlighted in the sources is that guide wires should never be advanced against significant resistance. You don't force them.
Why not?
Because forcing a wire could potentially damage the artery wall. It could cause a tear, called a dissection, or even poke a hole through the artery, which is called a perforation. So the doctor is gently feeling their way through the blockage with the wire, using skill and experience.
Wow, it sounds like it requires incredible skill and a very delicate touch to navigate those tiny wires through blocked, hardened arteries.
It absolutely does. It's a very tactile and visual process for the physician. And they use various specialized catheters and wires depending on the specific situation, the size of the artery, the location, and type of blockage. The sources mention specific wire sizes, like tiny 0.018-inch wires used for arteries below the knee, which are really quite small. Sometimes crossing a particularly tough or long blockage from the usual access point, say coming down from the groin, which is called an antegrade approach, just isn't successful. In those cases, the sources describe using a second access point, perhaps accessing an artery down in the foot or lower leg, a retrograde approach, to try and get a wire across the blockage from the other direction.
So they come at it from both ends.
Exactly. That technique is called an antegrade retrograde approach. If they manage to get wires across from both sides, meeting in the middle, they might use a special tool, like a tiny snare, to grab the tip of one wire and pull it out through the sheath on the other side. This creates a stable wire connection, like a railroad track, all the way across the blockage. They call this through-and-through access, and it provides a very strong platform to then deliver the treatment tools over that wire.
That's really clever using two access points like that. So once they finally get that guide wire across the blockage, what tools do they use to actually open up the artery?
Right. Once a guide wire is successfully positioned across the blockage, various tools can be advanced over that wire to treat it. The most common tools are balloons. These are tiny folded balloons mounted on a catheter. They're positioned right at the blockage and then inflated with pressure. The inflation pushes the plaque aside and stretches the artery wall open, widening the narrowed passage. This specific procedure is called angioplasty.
Just inflating a balloon widens the artery.
Yes, in many cases. Sometimes, though, especially if the artery tends to spring back closed after the balloon is deflated, or if there's a tear in the artery lining, they might use a stent. Stents are small, expandable metal mesh tubes. They are delivered collapsed over a balloon catheter, positioned across the blockage, and then the balloon is inflated, expanding the stent and pressing it against the artery wall. The balloon is then removed, leaving the stent behind to act like a scaffold, physically holding the artery open.
Okay, so angioplasty uses balloons, and stenting leaves a metal scaffold behind. Are there other options?
The sources also mention atherectomy. This is a different approach where specialized devices are used to physically remove the plaque from the artery wall, sort of like shaving it away or pulverizing it. The sources mention it as another potential strategy, although the specific details of exactly when and how it's used for PAD in these particular sources are less extensive compared to angioplasty and stenting.
Got it. Balloons, stents, or sometimes plaque removal.
Right. And throughout this entire process, navigating wires, injecting contrast, inflating balloons, placing stents, the medical team is constantly using that angiographic imaging, the X-rays, to guide their work and see exactly what they are doing inside your arteries. Now, this does involve using X-rays, which are a form of ionizing radiation, and while it's absolutely necessary for performing the procedure safely, the sources emphasize that minimizing radiation exposure for both you, the patient, and the medical team is always a priority. They use various techniques like using the lowest possible X-ray settings, limiting the time the X-ray beam is on, using protective shielding, and operate the equipment optimally to keep the radiation doses as low as reasonably achievable.
That's good to hear they're conscious of radiation safety.
Absolutely. So the ultimate goal of all this is to restore healthy, robust blood flow through that artery that was previously narrowed or blocked. Towards the very end of the procedure, after the treatment is done, the doctor will usually perform another angiogram. They inject contrast again and take final x-ray pictures. They're carefully checking the result, looking for the artery to be widely open with good, brisk blood flow down the leg, and making sure there are no new issues like residual narrowing, significant tears, or blood clots filling defects. They might also use other methods right there on the table to confirm good blood flow, maybe using a handheld Doppler ultrasound probe over the artery further down the leg, or by checking if they can now feel strong pulses in your foot that might have been weak or completely absent before the procedure.
Wow. That is truly a detailed picture of what happens inside your body during this procedure. It sounds incredibly complex, using all these tiny wires and tubes and real-time imaging to fix problems from within the blood vessel itself. It's quite remarkable, really.
It really is sophisticated, isn't it? And the sources also mention, just briefly, that the medical team always needs to be prepared for unexpected things, for contingencies. For example, they need to be ready and have the equipment available to quickly access the artery in the opposite groin if the initial attempt on one side were to cause some kind of vessel injury or complication. It just highlights the importance of having backup plans readily available for safety.
Right, always prepared. Okay, so the procedure itself is successfully completed. What should you, the patient, expect immediately afterward? You moved out of the procedure room, probably to a recovery area. What happens then?
Exactly. Once the endovascular procedure is finished, you'll be moved to a recovery area, sometimes called the post-anesthesia care unit, or PCU, for close monitoring. The immediate priority now shifts to managing the site where the artery was accessed. A primary focus right away is achieving hemostasis. That's the medical term for controlling bleeding at the access site where the sheath was inserted. If the access was in your arm, say the brachial artery, they will likely apply firm manual pressure directly over the site or use a specialized pressure device for a specific period. One source mentions 15 minutes for brachial access, for example. This pressure helps the small hole in the artery to seal up.
Okay, pressure on the arm. What about the groin? That seems more common.
Right. If the access was in your groin, which is most common for leg procedures, achieving hemostasis might involve several methods. It could be prolonged manual pressure applied by a nurse or doctor. Or they might use a mechanical clamp-like device that applies pressure for a set time. Alternatively, and increasingly common, they might have used a special closure device at the end of the procedure right before removing the sheath. These devices work from inside the vessel to plug or stitch the small hole in the artery wall. Now, depending on which artery was accessed, arm versus groin, and how that access site was closed, manual pressure closure device, you will receive very specific instructions on how long you need to keep that limb, your leg, or arm perfectly straight and limit your movement.
The dreaded lie flat and keep your legs straight.
That's often part of it, yes, especially with groin access closed by manual pressure. For brachial access in the arm, the sources mention the arm might need to be kept straight on an arm board for several hours, maybe up to 4 hours, and you'd need to limit using that arm significantly for a full 24 hours. If you had groin access, you might need to lie flat in bed with your legs straight for anywhere from 2 to 6 hours or sometimes longer, depending on the sheath size and closure method. It is absolutely crucial to follow these instructions about keeping the limb straight and still, exactly as you're told. It allows that puncture site in the artery to heal properly and prevents potentially serious complications like bleeding or developing a large hematoma.
Okay, follow those instructions to the letter. What else happens in recovery?
While you're resting and keeping that limb still, you'll continue to be monitored very closely by the nursing staff. They will regularly check your vital signs, blood pressure, heart rate, breathing, oxygen levels. They will also frequently check the access site itself, looking carefully for any signs of bleeding, like blood soaking through the dressing, or any swelling or increasing tendiness, which could indicate bleeding under the skin. And, most importantly, they will be regularly checking the blood flow in your leg, or foot, or arm, if access was there, on the side where the procedure was performed. They'll do this by checking the pulses, looking at the color and temperature of your skin, checking sensation, and making sure you can wiggle your toes or fingers. This is to ensure that the improved blood flow achieved during the procedure is being maintained and there are no new problems.
Constant vigilance, it sounds like.
Very much so. Medication management also continues in the recovery period. We talked about antiplatelets before, and if a stent was placed during your procedure, taking your prescribed antiplatelet medication is especially critical starting right away. These drugs help prevent blood clots from forming inside that new stent, which could otherwise block the blood flow again relatively quickly. The sources provide an example from carotid artery stenting that's in the neck, where dual antiplatelet therapy, usually aspirin plus clopidogrel, is recommended for at least 4 weeks, often followed by one antiplatelet drug, like clopidogrel, long-term, maybe indefinitely.
So that combination is pretty standard after stenting.
It often is, but the exact drugs and duration depend on the location and type of stent and your individual risk factors. While that specific regimen is for carotid stenting, it clearly illustrates the critical importance of antiplatelet drugs after stenting procedures in any artery. It really highlights the need for you to stick strictly to the specific antiplatelet prescription your doctor gives you for your peripheral artery procedure. Don't miss doses. Pain management will also be available, of course. You might have some discomfort at the access site or maybe some mild ache in the treated limb. They'll provide medication as needed to keep you comfortable while you recover. And lastly, the sources mention the use of something called a debriefing checklist after surgical procedures. This is a way to ensure all the critical information about how the procedure went, any issues encountered, and any specific patient needs for recovery are clearly communicated from the procedure team to the recovery team. This kind of clear, structured handover is likely part of the process after an endovascular procedure too, just to ensure everyone caring for you is fully informed and your recovery goes smoothly.
Okay, so the focus right after the procedure is really on managing that access site to prevent bleeding, keeping the limb still exactly as instructed, continuous monitoring of your vitals, and, crucially, the circulation in that limb, and starting or continuing those all-important antiplatelet medications if a stent was placed. It's definitely a period of watchful recovery.
Exactly. It's a critical time for that initial healing and stabilization before you're ready to head home.
And that brings us perfectly to discharge. What should someone expect, and what are the most important things to remember and do once they are cleared to go home after the procedure?
Right. Once your healthcare team determines that you are stable, your recovery is progressing well, maybe you're up and walking a bit and you meet their specific criteria for discharge, you'll be able to go home. And that's obviously a significant and welcome step in your recovery journey. Before you actually leave the hospital, you'll receive a set of very detailed discharge instructions. These are crucial, so pay close attention and make sure you have someone with you, if possible, to listen to. These instructions will cover pretty much everything you need to know for your care at home. This includes specific guidance on how to care for the access site, wound, the little puncture site.
What kind of wound care is usually needed?
It's often quite simple. You'll be told how to keep it clean and dry, maybe change a small dressing if needed, when it's safe to shower. Usually you need to avoid soaking it in a bath for a while, and very importantly, what signs of infection or problems to watch for at the site. Following these instructions carefully is paramount to prevent complications like bleeding restarting or getting an infection there. The instructions will also cover any activity restrictions you need to follow.
Like how long to take it easy?
Exactly. You'll typically be encouraged to gradually increase your activity as you feel up to it, get back to walking. But it's very important to avoid any strenuous activity like heavy lifting or intense exercise for the specific period your doctor advises. This might be a few days or maybe a week or more, depending on the access site and how the procedure went. They'll provide clear guidance on when you can safely return to your normal daily activities and work. And of course, the instructions will include your schedule for taking medications. Adhering to your medication regimen exactly as prescribed is absolutely vital once you're home. As we've stressed, this will almost certainly include antiplatelet medication, especially if a stent was placed. These medications are essential for preventing blood clots from forming in that newly treated artery and ensuring it stays open long term. Your doctor will tell you precisely which medications to take, the correct dose, and for exactly how long, which might be many months, years, or even lifelong. It's critical not to stop or change these medications without talking to your doctor first, even if you feel fine.
Okay, medications are non-negotiable. What else?
Knowing the potential warning signs of complications is also key once you are home. We're going to cover these specifically in the next section, but understanding what to watch for empowers you to seek medical attention quickly if something doesn't seem right. Your discharge instructions should review these. And finally, the instructions will detail your follow-up appointments. These appointments are a crucial part of monitoring your recovery and managing your peripheral arterial disease long-term. They allow your doctor to check on your progress, examine the access site, and assess your circulation. These follow-ups may also involve non-invasive tests, like that duplex ultrasound we talked about earlier.
To check if the artery is still open.
Exactly. Duplex ultrasound is a really valuable tool that can check the patency, the openness of the treated blood vessel, and assess the speed and quality of blood flow over time. The sources indicate it's a key method for surveillance after these procedures, similar to how it's used to monitor bypass grafts after surgery. So those follow-up scans are important.
So going home really means taking an active role in your own recovery diligent wound care, following those activity limits carefully, being absolutely perfect with your medications, knowing the warning signs inside out, and definitely keeping those follow-up appointments and scans. It's like continuing the care plan just outside the hospital walls.
Exactly right. Your active participation and adherence to the plan are essential for a successful recovery and for managing your overall vascular health moving forward.
Okay, that leads us perfectly into talking about the future and managing this long term. Peripheral arterial disease is, as you noted right at the beginning, a chronic condition. The procedure fixed a specific problem area, maybe opened up a blockage, but how can someone actively work to avoid the disease progressing or new problems popping up somewhere else in the future? This touches on both preventing recurrence in the treated area and just general long-term management of the underlying disease.
This is perhaps the most critical long-term perspective for anyone with PAD, whether they've had a procedure or not. The endovascular procedure was likely a highly effective way to fix a specific blockage, restore blood flow, hopefully improve your symptoms significantly, maybe even save a limb in severe cases. But, and this is the big but, it doesn't eliminate the underlying disease process. It doesn't cure the atherosclerosis, which is often active to some degree throughout your entire arterial system in your legs, your heart arteries, the arteries to your brain. Therefore, what you do consistently every single day after the procedure matters immensely for slowing down the progression of that atherosclerosis and reducing your risk of new blockages forming, either in the treated artery or elsewhere, and reducing the risk of future problems like heart attacks or strokes. This is where long-term conservative management comes in. This might have been your primary approach before needing a procedure, or it becomes the essential strategy after the procedure, continuing indefinitely.
Okay, so what are the pillars of this long-term management?
Well, there are a few key pillars, all strongly supported by the information in these sources. The first, and arguably one of the most important, is optimizing your medical therapy. The sources strongly emphasize the role of specific medications, particularly statins.
The cholesterol-lowering drugs.
Yes, although they do much more than just lower cholesterol. Statins have been clearly shown in numerous studies, including ones mentioned here, to significantly reduce the risk of major vascular events, things like heart attacks, strokes, or even death from cardiovascular causes in patients with PAES. They are consistently associated with improved outcomes. The sources mention potentially lower mortality, fewer major adverse cardiovascular events, MAC, and even improved amputation-free survival, especially in patients who had severe blockages, what's called critical limb ischemia. So statins are really a cornerstone of therapy.
And you mentioned they do more than just lower cholesterol. The sources hinted at something called pleiotropic effects. What does that mean?
Yes, this is one of those fascinating insights from the sources. The benefits of statins seem to go well beyond simply reducing your LDL or bad cholesterol levels. The sources suggest these pleiotropic effects, meaning multiple effects, include potentially stabilizing the inner lining of your blood vessels, the endothelium, making it healthier and less prone to damage. They can also help reduce inflammation throughout the body. And remember, atherosclerosis is described as a chronic inflammatory disease. The sources even mention C-reactive protein, or CRP, as a biomarker of inflammation and cardiovascular disease risk, and statins can lower CRP levels. Furthermore, statins are suggested to potentially help stabilize those vulnerable plaque deposits within your artery walls, making them less likely to rupture suddenly and cause an acute, dangerous blockage.
Wow, so taking your prescribed statin isn't just about hitting a cholesterol target number on a lab report.
Not at all. It's about actively working against the underlying disease process itself, reducing inflammation, stabilizing plaques, improving vessel health. It's really fundamental. The sources list various commonly available statins: lovastatin, simvastatin, pravastatin, fluvastatin, atorvastatin, rosuvastatin, pitavastatin, underscoring their widespread use and proven importance in managing atherosclerosis.
Okay, statins are key. What else is crucial for long-term management?
Beyond statins, managing all the other key risk factors for atherosclerosis is absolutely fundamental to your long-term arterial health. While the sources don't list every single one exhaustively in the specific context, the link between atherosclerosis and conditions like diabetes is incredibly strong. The sources mention that intensive diabetes treatment can positively impact cardiovascular outcomes. So, keeping blood sugar under tight control is vital if you have diabetes. Managing high blood pressure is also crucial. While it was mentioned here in the context of aneurysm management, the use of antihypertensive medications speaks to the general importance of good blood pressure control for overall arterial health. High pressure puts extra strain on artery walls, and perhaps most significantly, especially if it applies to you, is smoking. Smoking is a major driver of atherosclerosis and PAD. Although not specifically detailed for PAD outcomes in these particular source excerpts, the overwhelming evidence from broader medical literature makes it crystal clear. Quitting smoking is probably the single most impactful lifestyle change you can make to slow or halt the progression of your vascular disease.
Quitting smoking is huge.
Absolutely huge. The sources also reiterate the benefit of antiplatelet therapy, like the aspirin and clopidogrel we discussed for preventing blood clots associated with atherosclerosis, atherothrombotic events. Your doctor will determine if ongoing long-term antiplatelet therapy is appropriate for you based on your individual risk factors, the procedure you had, especially if you got a stent, and balancing the benefits against any bleeding risks. And finally, physical activity. This is incredibly important as part of long-term conservative management. While the sources specifically highlight supervised exercise therapy as a key component for managing intermittent claudication, that specific type of leg pain or cramping that happens with walking and improves with rest.
Right, the exercise programs for PAD.
Exactly. Those structured, supervised programs are well-established treatments to improve walking distance, reduce claudication symptoms, and improve quality of life. The sources even compare supervised exercise therapy with or without revascularization, like the endovascular procedure, for claudication, reinforcing just how beneficial exercise is. But beyond treating claudication, just regular physical activity in general, walking, swimming, cycling, whatever you enjoy and can do safely, helps improve overall circulation, helps control weight, blood pressure, and blood sugar, and contributes significantly to overall cardiovascular health. This is vital for managing PAD long term and helping to prevent disease progression anywhere in your body.
Okay, so managing PAD long term is really a comprehensive ongoing strategy. It's about consistently taking the right medications, like statins and maybe antiplatelets. It's about aggressively managing other health conditions like diabetes and high blood pressure, making those crucial lifestyle changes, especially quitting smoking, and staying as physically active as possible. It's really about partnering with your healthcare team and actively managing the disease every single day, isn't it?
That's the perfect summary. It really shifts the focus from thinking about the procedure as a one-time fix to understanding PAD as a lifelong condition that requires ongoing management and a commitment to a healthy lifestyle to achieve the best possible long-term outcomes.
That paints a very clear picture. The procedure might have fixed a specific spot, maybe got you out of immediate trouble, but the ongoing work of managing the underlying chronic disease through medication, lifestyle, and activity is absolutely essential for preventing future problems and living well with PAD.
Precisely. It empowers you to take control of your health moving forward.
Now let's circle back to something we touched on briefly, but it deserves its own focus because it's so critical, especially in the period after discharge. Let's talk about warning signs. What specific signs or symptoms should someone who has had this procedure or their caregiver be watching out for once they are home that could indicate a potential problem and require immediate medical attention?
Yes, this section is incredibly important. Forewarned is forearmed, as they say. While, as we've mentioned, endovascular procedures are generally very safe, complications can sometimes occur, either shortly after the procedure or even later on. Knowing what to look for can make a critical difference in getting timely treatment and preventing more serious consequences. The sources touch on several potential issues related to these vascular interventions that you need to be aware of. First, let's talk specifically about the access site itself, that little spot in your groin or arm where the catheter was inserted. You need to watch that area carefully. You should look for any significant bleeding. A tiny bit of oozing might be okay initially, but any bleeding that doesn't stop even if you apply firm pressure for 10-15 minutes needs attention. Also, watch for any expanding bruising or swelling around the site. A small bruise is common, but if it's getting noticeably larger, harder, or more painful, it could signal a hematoma, that collection of blood under the skin we mentioned earlier, which might need to be drained. Increasing pain at the access site rather than gradually improving pain is another warning sign. And definitely look for any signs of infection. Increasing redness spreading out from the site, the area feeling unusually warm to the touch, or any pus-like drainage from the wound, Any of these access site issues should be reported to your doctor promptly.
Okay, so watch the access site closely for bleeding, big bruises, worsening pain, or infection signs. What about problems related to the leg or foot itself?
Right, these are often the most critical warning signs, as they can relate directly to the blood flow in the treated limb. Problems here often require immediate medical attention because they could indicate something serious like acute limb ischemia, that sudden, severe lack of blood flow that can actually threaten the viability of the limb if not treated quickly. So, what should you watch out for? Worsening pain in the leg or foot is a key sign, especially pain that starts when you are resting, not just when you're walking. New or significantly worse pain at rest is a major red flag. Other critical signs include numbness or tingling sensations, often described like pins and needles. The medical term is paresthesias. The leg or foot feeling unusually cold to the touch compared to your other limb, the skin on the leg or foot appearing unusually pale or white pallor, or maybe even developing a bluish or mottled discoloration. And in severe cases, you might experience sudden weakness in the leg or foot, or even the inability to move your foot or toes properly, what they call paralysis or motor deficit. These symptoms, pain, especially at rest, pallor, paleness, paresthesias, numbness, tingling, pulselessness, though you might not check this yourself, and paralysis weakness are sometimes referred to as the classic PS of acute limb ischemia. The sources mention these as signs of a serious, urgent problem with blood flow.
Those sound like very serious symptoms that absolutely cannot be ignored. You need to get help immediately if you experience those.
Immediately. Don't wait. Call your doctor right away or go straight to the nearest emergency room. Time is absolutely critical when dealing with potential acute limb ischemia. The sources mention potential complications that can actually happen during a vascular intervention, like a dissection that tear in the artery wall or acute thrombosis, which is a sudden blood clot forming either in the treated segment of the artery or perhaps traveling down from higher up. If these issues weren't fully recognized or resolved during the procedure itself, or if a new one develops shortly afterward, like a clot forming in a new stent, it can lead to that severe reduction in blood flow and cause those urgent symptoms we just described.
Okay. Are there any other, maybe less common complications to be aware of?
Yes, the sources mention a couple of other possibilities. One is the formation of something called a pseudoaneurysm at the access site. This is different from a simple hematoma. It's essentially a contained leak from the hole in the artery that forms a pulsating sac or collection of blood connected to the artery. So if you notice a new lump near where the catheter was inserted, especially if it feels like it's pulsing or throbbing when you touch it, that could be a pseudoaneurysm and should be reported to your doctor. They often require treatment. And while it's generally considered less common in peripheral arteries compared to some other locations, like veins used for dialysis access, issues like stent migration, where a stent physically moves from its intended position, are mentioned in the sources as potential complications of stenting procedures in general. So any new or significantly worsening symptoms after you've had a stent placed, even if it's sometime later, should prompt you to contact your doctor for evaluation, just to rule out any issues with the stent or the treated artery. So the overall message here is really clear. Sudden or severe pain, particularly in the treated leg or foot, should never be ignored after this type of procedure. If you experience any of those warning signs we've discussed, significant bleeding or expanding swelling at the access site, signs of infection there, or especially any of those critical signs of reduced blood flow like new or worsening pain at rest, coldness, paleness, numbness, or weakness, you absolutely must contact your healthcare provider right away or go directly to the nearest emergency room. Don't delay. Don't wait to see if it gets better on its own. Get it checked out immediately.
That list is incredibly valuable, and stressing the urgency is so important. Knowing exactly what to look for really empowers you, or your caregiver, to be vigilant during that recovery period and get help when it's needed most.
It absolutely does. Being informed and knowing when to act quickly can be crucial for ensuring the best possible outcome.
Wow. Okay. We have covered a tremendous amount of ground today. We've really walked through the entire experience, haven't we? From getting ready for your peripheral arterial disease procedure, understanding what happens during it, what to expect right after and when you go home, what warning signs to watch for, all the way through to understanding how to manage the condition for the long haul.
And I think by breaking it down this way, step by step, you can really see how each part connects to the next. You know, the careful preparation really does set the stage for a safer procedure. Understanding what actually happens during the procedure helps to demystify it, maybe reduce some anxiety. Knowing what to expect in recovery helps you focus on healing properly. And perhaps most importantly, understanding those long-term steps empowers you to actively manage the underlying disease and work towards preventing future problems.
And it's just crystal clear from all these sources we looked at that you, the patient, or you, the caregiver listening, are absolutely central to this whole process. It's not just something that happens to you. Your engagement in the preparation, your vigilance for those warning signs after going home, and especially your commitment to those long-term strategies, taking the medications faithfully, making the necessary lifestyle changes, keeping up with follow-ups, they all play a huge, huge role in the overall success of the procedure and your future arterial health.
Absolutely. Knowledge is most valuable when it's understood and then applied. Being informed allows you to be a proactive, engaged partner in your own care journey, which is always the goal.
So thinking about everything we've learned today from these sources, the description of atherosclerosis, not just as plumbing problem, but as a chronic inflammatory disease, the surprisingly broad effects of medications like statins that seem to do so much more than just lower cholesterol by actually influencing inflammation and maybe stabilizing the plaque itself. Thinking about the role of mechanical forces, blood flow patterns on the artery walls, and the body's complex responses to all of that. Here's where it gets really interesting to think about the future. What if the deepest understanding of that truly intricate biological dance, the interplay between inflammation, the behavior of cells within the artery wall, and the physical forces exerted by blood flow? What if that understanding holds the key not just to treating blockages after they form, but to entirely new ways of preventing plaque from forming significantly in the first place? Could that deep biological insight potentially unlock a new era in cardiovascular medicine, one focused on truly halting or maybe even reversing the disease process itself, perhaps even more effectively than our current methods? It's certainly something fascinating to think about as you move forward, armed now with this roadmap for your own journey with PAD.